Greetings everyone, I'm Tim Sladden. I'm an HIV advisor with UNFPA, the Population Fund, and welcome to this first webinar of the Key Populations Community of Practice under the auspices of the Global HIV Prevention Coalition. And now the community of practice is established, now's the time that we should start to get active and activate what we can to support key populations and strengthen HIV and sexual health, sexual and reproductive health and other programming with and for key populations. So it's my great pleasure to chair this meeting today. And we've started off, we thought, with an important topic. You'll see this first slide is on our just some logistics. We're recording the session as well, but there is interpretation available for those who wish to listen in a different language. And there's the Q&A box at the bottom. We all know these functions now from Zoom. Perhaps we can go to the next slide. So really we want today to look at what are the key ingredients or the key elements that we need for really making a difference in our programming with key populations. What's going to make an impact? And we've identified 4 different aspects of programming that we think are important. There may well be others, and we've given plenty of time for discussion. If we can go to the next slide. Here's just an overview of the agenda. I won't go through it. Hopefully you've all managed to see it, but we've got 4 interventions, and then we will go into, we've got about half an hour of time for reflection, questions and answers, and what you feel are important elements. Maybe we haven't covered everything, we probably haven't. So we much look forward to your ideas about what is important to have impactful programming with key populations. And then we'll summarize things at the end. So next slide. So and then I'm going to give this short introduction, the next slide. So as I mentioned, the community of practice, it's really a platform for open discussion. And we have a good structure now. We're going to have this series of webinars through the year, and we welcome ideas for topics that you think we should cover. We also have a newsletter, which we've started to produce. And now we're thinking about some sort of open discussion platform for emerging issues or acute and difficult situations. For example, we have a situation of sex workers being targeted in Afghanistan now. So I think some sort of discussion where we can have a free and open discussion about how we can support key populations as acute and difficult situations arise. COVID has been very difficult for many key populations. So this session today, we want to build our understanding of what are the building blocks, the ingredients of effective programming with key populations. We want to learn from country examples and good case studies that will be presented. And the fundamental and the most important point, I think, is that we reinforce the need for all of our interventions really being community-led, community-owned, and administered and operationalized by empowered communities. So we're going to start off first. We have Parinita from the South-South Learning Network, who's going to give us a brief talk about trusted access platforms. And I think this is a fundamental foundation to what we need to do when working with key populations. Parinita, please take the session.
Thank you so much. Good morning, good afternoon, everybody. I'm going to talk about building a strong foundation for a scaled and effective HIV response with key population, with special emphasis on building a trusted access platform. Next slide, please. Key Population Trusted Access Platform, it's a guidance document available in the GPC website. The focus of the Key Population Trusted Access Platform document is to share the principles of building a solid foundation for key population service provision. A trusted access platform is a foundation on which effective key population programs are built and a range of community and facility-based interventions and services are provided. Sorry. A trusted access platform supports all key populations, both as individual members and communities, addressing common needs regardless of HIV status or other specific health care requirements. It is also a way of working with key population communities to establish trust and improve access to services involving close collaboration on program design, implementation, monitoring, and on addressing critical enablers. Trusted access platform may be implemented by community-led organizations, KP-led organizations, non-governmental organizations, or civil society organizations in collaboration or with support from government and donors, but they derive their effectiveness from the engagement and participation of active key populations. Access platforms may be physical, virtual, or a combination of two, but they will eventually entail contact between program recipients and program providers. So a trusted access platform at local level are building blocks for a scaled up national program for key populations. Next slide, please. There are several key population implementation tools, and you may have seen many of them. The sex workers implementation tool, the MSM implementation tool, the transit, IGWIT, and they are the primary references for the Trusted Access Platform Guidance document. And they should be, these documents, the implementation tools should be consulted for more details on designing effective key population programs. The Trusted Access Platform Guidance does not go into detail about specific package of services, which you will find in the implementation tools. Rather, this document focuses on building of a foundation for key population service provision, one that enjoys high levels of trust and participation with and by key populations in community and clinic settings. Next slide, please. The document has 12 chapters split into two parts. The first part focuses on intervention design for impact, and the second part focuses on management for scale and coverage. The document also has 4 annexures which provide practical examples. The unique feature of the document is that each chapter ends with a summary of what is needed and what needs to be budgeted. The budget guidance provided in this document helps in understanding general resource need for each activity. Hence, this could be a useful document for also proposal writing. Next slide, please. Trusted Access Platform has several advantages over narrowly designed programs. Experience has shown that a single focused program, like a program only for condoms or for HIV testing or for PrEP, often struggle to reach many key populations, especially those at highest risk, resulting in a low service uptake, use, retention, or impact of the program. Additionally, if these vertical services are able to reach individuals, there's always a missed opportunity for a comprehensive encounter. Hence, as a platform, coordinated community and facility-based efforts, they combine to build trust, reach each key population, especially in high numbers, and encourage their uptake, retention, and active participation in program. Next slide, please. What are the main elements of a trusted access platform, especially in relation to developing an intervention designed for impact? So trusted access platforms are built in close proximity to key population communities, and they maintain a continuous presence in places, whether it's physical or virtual, where these communities meet. This means continuous consultation and engagement with key populations to understand their needs and preferences. This continuous engagement is facilitated by peer educators who are engaged by the program based on their knowledge of the venues and locations and their rapport with the peers. In addition, safe spaces and structural interventions are critical enablers. Safe spaces enhance outreach by providing security and building community trust. These spaces need to be welcoming, secure, and provide opportunities for rest, networking, meetings, and clinical services where feasible. Safe spaces like drop-in centers, as they are called in many countries, provide simple amenities that attract key populations and facilitate community cohesion and networking. Structural interventions make the local environment safer for key populations and reduce barriers to prevention and service utilization. Addressing structural issues build trust, remove or mitigate barriers to prevention and service access, and improve conditions. A range of structural interventions, including addressing unfavorable legislation or policy, addressing violence, stigma, and discrimination against key populations, community empowerment, and safety and security, have been effectively implemented by key population communities with program support. Next slide, please. Other elements include strengthening outreach. As mentioned earlier, peer educators are a critical part of community outreach. So programs should budget for sufficient number of peer educators and supervisors based on the population. It's important to budget for the remuneration, phone or travel reimbursements, initial training, and refresher training. Peer education based in venues is a starting point for also micro-planning, which empowers key populations to lead outreach efforts, especially because it builds on knowledge that peer educators have of their communities and to share their experiences with the other key populations who live, work, or meet there. Micro-planning helps peer educators to understand individual needs of the key populations in their cohort and plan for each person based on their needs. Together with education and on prevention and treatment, condom, lubricant, and needle syringe distribution and promotion are main components also of community outreach. HIV self-testing kits also may be included in outreach. Effective condom, lubricant, needle syringe programming for key populations require integration and coordination between outreach and clinical services, and it can be supported by regular planning and programmatic monitoring against targets that are set. A wide mix of service delivery models can be chosen based on preference of the community. Peer educators create demand for preventive and curative services at the community level and mobilize key populations to visit the program clinic for routine checkups. Regular medical checkups, where a wide range of clinical services are offered, are promoted for all key populations regardless of their HIV status, maintaining confidentiality and building trust. Additional program efforts to promote HIV testing, uptake of PrEP or ART work best to boost the uptake, adherence, and retention when implemented from a trusted access platform. Promoting checkups rather than specific services safeguard medical confidentiality and builds community trust. Next slide, please. Management for scale and coverage is important for a KP program. So key population programs built on trusted access platforms rely on programmatic data for continuous planning and monitoring progress. This information starts with the most current available estimates of key population locations and population sizes. Mapping with population size estimates are critical activity at the central level in order to plan for scale and coverage, and at local level to guide programmatic efforts. Several mapping and size estimation strategies and approaches are available both at physical and virtual sites. Coordination and mechanism to manage the response at all levels, starting from implementation level to the national level, is very critical. Structures like technical working groups, which are there in many countries, or committee of experts, is essential to ensure that the response is coordinated and there is effective communication between all stakeholders involved in the key population program. Key population-led organizations and key population networks play a very important role in ensuring that feedback from the country is communicated feedback from the community is communicated through these coordination mechanisms, and action is taken based on suggestions and feedback of the community. Next slide, please. Program monitoring of trusted access platforms measure the extent to which key populations are being reached the community and are using community and facility services. Program monitoring is a very important management element for scale and coverage. Targets are established using population size estimates as denominators, and progress is reviewed monthly, quarterly, annually. These basic performance data enable reliable monitoring of specific services, including uptake, utilization, and retention. Next slide, please. Quality of service provision determines whether services are used, and it requires continuous community input, and we talk about community-led monitoring now. Several community qualitative monitoring methods, from peer-mediated feedback to community meetings and community-guided quality monitoring, can be done. Robust routine program monitoring systems with core indicators standardized across key population help programs in assessing progress and gaps. Assessments need to be done also to understand whether programs are making a difference in terms of key outcomes like use of condoms, lubricants, needles in syringes, and the impact on HIV and STI acquisition and transmission among key populations. In addition to routine monitoring data, surveys, mathematical modeling exercises, and special studies can be also done. Next slide, please. Key population programs also need capacity building, especially for community and staff. Staff development requires a capacity building mechanism or a technical support mechanism that includes training and supportive supervision based on standards. Community empowerment is also a progressive process arising from well-implemented key population programs that can be facilitated by a range of community system strengthening activities. Self-help groups, developing networks, KP-led organizations are examples of community systems strengthening that empower key populations to identify specific conditions. Could be violence, could be financial vulnerability, and take steps to solve them. As key population communities become organized, strengthening organizational and institutional capacity is an important component of sustainability and management for scale and coverage. I would end my presentation here. Thank you so much. Tim, over to you.
Thank you very much, Parinita. An excellent staying time as well. Very interesting overview of the way we have to be systematic, but also inclusive in establishing a trusted platform or space in which we can develop our programs. Really excellent that this is a foundation on which we should build all of the programming. So now we're going to turn to Purvi Shah, who is a regional consultant with UNAIDS in the Asia and the Pacific, and also WHO. And we need to be innovative, so we're going to look at the use of virtual interventions in our key population programming. Purvi, you have the floor.
Thank you very much, Tim. Am I audible?
Yes, I can hear you loud and clear. Yep.
Okay, great. Thank you so much. So good morning, good afternoon, and good evening, everybody. And thank you for this opportunity to share some of the information on virtual interventions. So because of the shortage of time, what I've done is I've just divided my presentation into three main parts, which would be innovate, implement, and integrate. We can move to the next slide. So when we talk of innovations, I think when we think of virtual interventions, one thing that comes to our mind is, how do we innovate? How do we think of new methods of reaching our key populations? I think it's very important to move in the direction in which we actually have our key populations moving. So as we know, most of the key populations are now moving on to social media platforms and dating apps. And so it was, identified as a gap where we were not able to reach out to this population that we would otherwise be missing in our traditional outreach or the national programs. So when we talk of innovations or virtual interventions, there can be two types of innovations. One could be internet-based, like countries which have good internet connections could use internet-based platforms, or the other one could be phone-based interventions, which only uses a simple phone. Basically, innovations should be designed in a way that we can broaden our reach, because as we know that populations that we find on virtual spaces are a little different than the populations that we find offline. They are the more discrete, hidden populations, and they don't necessarily identify themselves as key populations, but are equally vulnerable and are in need of services. This virtual interventions and other types of innovations can actually help us to broaden our reach and reach out to this other vulnerable population as well. Virtual interventions also allows us to offer differentiated service delivery. So we need not give a standard package of service to everybody, because everybody that we find has a different need and requirement. It differs population-wise, and it also differs, based on their risk behaviors. As we all know, I mean, COVID-19 has hit our lives since the last 2 years, almost 2 years now. And I think that, it's important to start finding solutions, or rather a lot of people have already started finding solutions. And I think virtual interventions can definitely play a very important role as a solution to mitigate the impact that COVID-19 has had on all our programs. It also allows us to have a targeted reach and improved efficiency. We can't reach everybody, we can't test everybody. It is important to target the audience that we want to reach, and therefore improve our efficiency, and thus probably also control costs as a result of that. There are different approaches that can be used to innovate with key populations. It could be virtual outreach, it could be influencers, and it could be advertisements as well. The video that you see on the screen right now is of an influencer who actually just developed a very simple video of herself booking an appointment on a virtual platform, and then easily landing up at a facility to get tested without any compromise on confidentiality, any fear of stigma discrimination. Next slide. This is an example of an online framework. So this is something that I would look at while I'm planning to implement virtual intervention. So this is just an example. You can adapt this, or you can change it based on the country requirements and context. The upper part of the diagram is the usual HIV cascade. So this basically, I'm trying to tell you that virtual interventions is not just restricted to prevention or testing. It runs across the cascade. It needs to flow across the cascade. We need to take the individual right from prevention to testing to treatment to viral suppression. Below the cascade, you can see the approaches that are mentioned that could be used to actually help you take this individual from each of the bars in the cascade. So details are available on the FHI 360 website if you need. And we also have a technical brief which is being developed by UNAIDS and WHO, which will also have details of this framework and all the approaches that are mentioned here. Next slide. And the third part that I feel is the most important part is integrate. Virtual interventions has been going on since the last 3 years, with COVID or without COVID. But I think what is now important as programs is that we would integrate virtual interventions as part of our national program. So it can't run as a silo, it can't run as a parallel program. It needs to be integrated, it needs to be a part, it needs to be a choice that has to be given to the key population, and whether they want to access services virtually or in the physical spaces. So by no means we are looking at replacing physical outreach or physical interventions. This is just going to supplement, basically to help us bridge the gaps. It will also basically, integration would help us reach key population at scale, or rather, kind of bring this whole intervention to scale. It is important to bring it to scale. Right now, it's being done in pockets. It's being done by projects as pilots. We need to scale it up now. There needs to be community ownership and leadership. I think integration would help us gain that as well. And community ownership will actually push the integration at the national level. Policy brief and guidance is something that is missing right now. And if we can integrate virtual interventions into the existing policy briefs, guidelines, guidances that are available for key population programs, I think that will really help the countries decide and plan virtual interventions. Safety and security measures also need to be considered. And most importantly, integration of virtual interventions in the existing platforms will actually help us save time and money. We can adapt the existing platforms to add components of virtual interventions. Next slide.
If you can wrap up.
Thank you.
Oh,
And yes, thank you. And I'll be happy to answer if there are any more questions. Thank you.
Thanks very much, Purvi. A lot to take in, but we have the slides, but some very useful flow charts there and innovative approaches that we need to take into our programming. So now we're going to hear two presentations, two very good case studies that we have for you, and really looking at how do we get to scale. Often we have projects that are quite small or funded locally, but we need to think about national programs that will really reach a significant number of people in the interventions that we put forward. So first we're going to hear from Pavlo Smyrnov, who's from the Alliance for Public Health in Ukraine. And after him, we will have Mary Mugambi from NASCOP in Kenya. So Pavlo, please, will you give us your intervention for about 10 minutes, please? Just go through Mary's slide. Here we are. Yeah, thank you.
Hello, everyone. I will present a case from Ukraine, and please move to the next slide. So, of course, as every program needs size estimation, we do it in Ukraine as well. It's done regularly, almost every 2 or 3 years. And what I want to point out here is that we don't only have a national size estimate, but more like a regional level. And there is a number of steps we use to validate those estimates and have a consensus on the national and regional level on those numbers. Next slide, please. And not only stopping on the regional size estimates, we also do some kind of a more precise location mapping. Like on this diagram, you can see there is data coming from mapping exercise before we started IBBS this year among people who inject drugs in Kyiv city, capital of Ukraine. You can see there is a number of locations where or venues where people who inject drugs are living or gathering, which are not covered by any outreach or stationary points. So this is kind of the dynamic information which we need to do regularly to see if there are any hotspots we need to move our services to. Next. Also, we have another, we kind of used another way to prioritize interventions regional-wise. And this is, for example, data coming from national MIS treatment and testing data on pregnant women. And you can see even the average would be kind of an average number doesn't mean that it's average across all the regions. So we can see there is a high prevalence in some districts among pregnant women, and there is a rising prevalence as well, which indicates a more risky behavior in recent years, which could probably mean that there is, for example, sexual partners of people who inject drugs or sex workers, and we need to look closer to those areas and see if we can cover these populations. Next. Also, I wanted to highlight that we have successfully transferred to the government funding in the second half of 2019. We had quite a high coverage supported by Global Fund. And of course, all those years, we've been advocating for government support, at least for the basic package. We have successfully advocated it. In 2019, government started to fund all basic package prevention services and care and support services for key populations. And as you can see, this was successful as we haven't dropped our coverage due to the transition. There's a slight drop among MSM population, but it was mostly related to some of MSM organization, community organization didn't want to participate in the government tenders. So we had new organizations coming in. They didn't have trusted access to this population. So there was some drop in coverage, but we're working on it and trying to build this trusted access to populations or engage community organizations to prevention work. And also there is a decreased number of subrecipients as well, as the government kind of budget imposes is more complicated. So it's mostly was a subtraction of the number of community organizations implementing the program. Okay, next. The next few slides, I wanted to actually focus on something that I would say is something that is beyond the scale. So once you have a basic package available in most of the regions and most of the hotspots, there will be still quite a number of clients or potential clients, I would say, not covered or not reached by any services. And this is evident from IBBS data. Almost every time we do IBBS, we can see about 30 to 40% of participants have not been reached by any of services. So this means that you need to do an extra effort to reach to these people. And this can be geographical, as I showed on the previous slides, or it can be using different technologies, like the one described here is optimized case finding based on social network strategy. Basically, we are trying to reach those unseen risk network clusters, and we are trying to also test, and we can see that there is a higher chance to find undiagnosed HIV cases in these groups. So this is one of the intervention which we actually add to the basic package funded by government, and this is funded by Global Fund and PEPFAR CDC support. And next slide. Here it's even more advanced. So we not only use social network strategy on stationary points. We have noticed that there are some areas not covered at all. Particularly a smaller city or kind of distant districts of the large urban areas where we don't have any stationary points or any services. So we can actually bridge this gap by using the mobile vans, and they combine venue outreach and social network strategy, plus they provide clinical services in the van, like they do the testing of HIV, HCV, TB screening. They can also provide ARV drugs in the van, and we also refer people to PrEP and methadone therapy. Okay, next. So of course, the monitoring and evaluation is a large, important part of the scale up and moving beyond scale. As you've seen, we do use the unique client code in all KP projects, which help us to see the individual based data on service coverage. We can do the cascade, cross-sectional cohort cascades. We also can actually validate this with MIS data, because for every positive, we have also a unique code which we call case plus, which is the same code which is used in the MIS system. So we can actually validate number of peoples who have been referred to ART and PrEP from the community projects with the data on treatment from the national MIS system. And another important piece of it is monitoring of human rights violations. We are using React database, which help us to collect information on all kinds of violations on excessive treatment or violence cases, and we can quickly follow up on those cases to make sure that the police or the health workers are not creating any obstacles to access services for key populations. And the next slide, the last one. The coordination management is also quite important piece we need to pay attention to. For example, moving to the government or mixed funding, government and donor funding, we actually need to make sure that we do focus our attention or our funding to people, to organizations who have been funded by government. We provide additional funding from donors to those organizations. There will be some areas where government have not subcontracted any organization, so we need to step in with the donor funding. So this is kind of a quite dynamic and changing environment we need to closely monitor and to allow coverage for all the areas, all the hotspots. What is important also is what I mentioned is if there's a change of subrecipient, there could be potential loss of access to key populations, and this should be also closely monitored. Sometimes we need to introduce direct operations for the complex interventions, like the one which I described as mobile social network strategy. It requires a lot of all kind of technical issues to be taken care about, like coupon management, payment incentives management. So this is quite complex, and sometimes we don't have a local partner to pick it up immediately. So then it goes to the next step on quality assessment, community monitoring, client feedback, mystery shoppers. This is what is continuously done to see if the services which are declared are really provided and at the quality level which is acceptable by clients. So the technical support and supervision is something that is really important to build the capacity of the local implementers. And finally, structural interventions, of course, should be in place to make sure that everything we create in terms of services will not be, there will be no barriers to access to those services because of some other factors like stigma, police violence, or any other human rights violations. Thank you very much.
Thank you very much, Pavlo. Fantastic intervention and showing how at scale does not mean blanket coverage everywhere, but really to be focused and to find the high impact locations through data and the importance of monitoring to really validate that the coverage that is achieved by this really quality program in Ukraine. Thank you very much. Do we have Mary now from Kenya?
Yes, I'm here. Can you hear me?
Yes, Mary, come in and present your case study. Thank you very much. About 10 minutes.
Thank you. I'll be presenting on the Kenyan context. Our HIV prevalence among key populations in Kenya is high, and our population size estimates of key populations are as stated here. We have about 206 FSWs, MSM around 50,569, and we have people who inject drugs at 19,691, and we have transgender people at about 4,305. So a national key populations program emerged in 2009 with the Ministry of Health, NASCOP and NAC taking the lead. And currently we have 36 in the 47 counties in Kenya. And we have funding support from the Ministry of Health, PEPFAR, Global Fund, and other donors. There are more than 100 implementing partners in Kenya. With for FSW, it's about 88%, for MSM, 79%, and for people who inject drugs at 93%, and 19% of transgender. Next slide. Our policy environment for the program, sex work, meaning same-sex relationships and drug possession and use is criminalized in this country. However, the key populations for us, who are the FSW, MSM, PED, and transgender people, are prioritized in the National Strategic Plan since 2009. And the National Guidelines for HIV and STI Programming with key populations was developed in 2014. And we also have the National Policy for Prevention of HIV among key populations developed in 2016. We also have our national guideline for HIV and STI programming for young key populations developed in 2018, and national guidelines for HIV and STI programming with transgender people developed in 2020, which was launched this year. So these are the latest. Next slide. So when we are planning for scale, for mapping and population size estimation is a key first step. And we carried out a geographical mapping approach in priority towns in 2012. And we had this participatory programmatic mapping approach in 34 counties, which was the one for MSMs we did virtually. And then since estimates were derived in counties without programs using mathematical modeling, the mapping and estimation exercise helped in identifying where and how many, helps in setting targets and implementation level. Participatory mapping identifies interventions, that is both local locations, venues, and KPs who operate in those location of venues. And the map here shows that. Next slide. So outreach is a very strong component for us for key populations. So we have a community outreach, which is prioritized with peer educators and outreach workers. And this is the backbone of the program. Peer educators who are key populations are selected from the mapped venues that we indicated in the map, and in many cases by the key populations community in the venue. Our peer educator key population ratio is specified in the national guidelines, where for FSW, it's 1 peer educator for 60 to 80 FSWs. For MSMs, 1 peer educator, 30 to 40 MSMs. And for PED, 1 peer educator for 30 to 40 PEDs. And for trans people, 1 peer educator for 30 trans people. So we have a supervisory cadre of outreach workers, which is critical, with 1 outreach worker for every 5 peer educators. Outreach workers who are also key populations interact with their peer educators on a regular basis, and this is to review performance and support for the planning and monitoring. For peer educators, we encourage them to perform well and progress to become outreach workers. That is a progression from one level to the next. Next slide. That's a photo of our outreach team, how we engage in community with continuous high-risk venue presence. Outreach teams are trained on peer education skills, planning at venue level for each key population member of their cohort using simple participatory tools. So as peer educators work within the venue location, they are expected to be present in the venue on most days. We have virtual sites which are emerging as venues, especially for MSMs, and hence virtual outreach is needed to make contact to provide services. And even now, considering COVID, things are getting virtual. Outreach services include provision of information and education, condom and lubes, needle and syringes, and referral to both static and outreach. The outreach team plays a critical role in mobilizing key populations to access clinical services and follow-up. Outreach teams also provide support to key populations when they experience violence. Next slide. So we have safe spaces, and a safe space or a drop-in center, these are also part of what we have put in the guidelines. As you can see, that is Reach Out Center, which is a drop-in center. There is a standard operating procedure which we developed on how to establish a safe space. There is a difference between a clinic and a DICE. DICEs are meant for relaxing, socializing, and normally designed by key populations. So key population organizations have better understanding of DICEs. Next slide. In our structural interventions, the focus has been on violence prevention and response. Awareness of rights among key populations, crisis response system, sensitizing and training with law enforcement, dialogue and advocacy with court user committees. So we've done efforts to reduce stigma and discrimination in the health sector. We also have key population-led organizations that have initiated economic empowerment activities in some of the DICEs, and then collectivization and strengthening capacities of KP-led organizations. That's also one of our focus in the structural interventions. In optimizing clinical services, we have a standard operating procedures for providing clinical services, different models. We have the static, we have standalones, we have outreach clinics, and we also have integrated clinics. For the comprehensive services, we offer HIV testing, sexually transmitted infections, we offer PrEP, we offer sexual and reproductive health, we also offer condom and lubes, and also ART special services are also offered. There's emphasis on quarterly checkup for all our key populations, irrespective of their HIV status, and we also focus on improving health-seeking behavior among them. And we also have a strong linkage between the community and facility teams so that there is communication on progress for our key populations. In monitoring performance, we have standard national tools, data collection and reporting, and this is irrespective of donor. And these data collection tools are simple for peer educators at the implementation level. These tools can be used for monitoring progress and reporting. And we have around more than 400 plus units who report monthly on the Kenya Health Information Systems and quarterly to the national program. So analysis of data and presentation is done in our quarterly donor meetings. We also have a quarterly national key population technical working group and quarterly county key populations technical working groups and monthly meetings within the implementation partners. We also have annual behavioral surveys using the polling booth survey method, which is rapid, scalable, and feasible and cost-effective. And we have development of cascades for gaps analysis and planning. Next slide. In terms of capacity building, we have a critical aspect of a KP program. We have a specific cadre-wise training, which is an outreach team of peer educators and outreach workers and advocacy workers and paralegals. We also have a clinical team comprised of the clinician, counselor, or nurse. Program management, we have prevention officers and managers, and we have joint training with stakeholders, the police, healthcare workers, and then we have trainer of trainers, which are conducted by the national program and capacity building plan, which is developed quarterly, and we have certification. For all the healthcare workers whom we train, we certify them using the NASCOP system. Managing scale, we have established a coordination mechanism at national and county level. And I talked about those meetings that are quarterly, allocation of counties to specific donors to avoid duplication, which we found as very important. Quarterly donor meetings to review progress, and joint meetings where we just look at solutions to address the gaps. Annual peer community feedback and annual stakeholders meetings to address critical program gaps are also what we do, and also technical support unit, which we have embedded within this national key populations program that really helps us to manage the program due to the shortage of staff within the ministry. Next slide. I think
wrap up, Mary.
That is it. Thank you very much, and thank you very much.
Thank you very much, Mary. Another excellent intervention and program in Kenya. You've always been very strong on the policy guidance and all of the guiding principles and the very systematic approach with standard operating procedures and very comprehensive in both outreach as well as providing drop-in centres and clinical services. So a very, very comprehensive program that enables you to reach at scale. But I think that policy supportive environment is so important that you have the buy-in of government and the national support for the program. Now we're going to move to the next session, and we're going to get to the heart of the matter about community leadership of our programming. Really, we know that the most effective responses are community-led and community-owned, and we have two wonderful participants from the African Sex Workers Alliance. We have Grace Kamau and Laveria Mwai, who's going to talk about community leadership and ownership. Grace, please.
Hi everyone. This is Laveria Mwai. Apologies, Grace Kamau won't be able to come in, but Charles Mukoma will be standing in for Grace Kamau. Okay, so let's go straight to the slides. So the African Sex Workers Alliance is a Pan-African alliance of sex workers-led groups that exist to strengthen the voices, to empower and to advocate for and advance the health and human rights of female, male, transgender sex workers, including those living in HIV and using drugs through networking movement, development partnerships, and capacity building. One of ASWA's mission is scaling up of community prevention through the Sex Workers Academy Africa, whose main objective is to build the capacity of sex workers-led groups in Africa to promote and implement the sex workers implementation tool, which is the suite. So in 2012, the World Health Organization, the United Nations Population Fund, the Joint United Nations Program, and Global Network of Sex Workers developed a guidance document on prevention and treatment of HIV and other sexually transmitted infections for sex workers in low and middle income countries. And this document has been highly used by some of the countries in coming up with the national strategic plans for key populations, like for example in Kenya, which you've just heard from Mugambi. And this document referred to as the 2012 recommendations set out effective interventions in the prevention of HIV treatment among other sexually transmitted infections. Next slide, please. So the Sex Workers Academy Africa is a south-to-south learning platform for sex workers, and its main focus of the tool is prevention and treatment of HIV and other sexually transmitted modules. The training modules focuses mainly on 6 main chapters, one which is community empowerment, and this is the foundation of the tool. This describes how empowerment of the sex worker community is both an intervention in itself and also essential to effective planning, implementation, and monitoring of all aspects of HIV and STI prevention, treatment, and care. We also look at addressing violence against sex workers, because we have come to see that when most of the sex workers are infected with HIV, the prevalence rate of violence is also high. And this focuses on one of the most urgent needs of sex workers: to be protected from violence, discrimination, abuse, and other forms of human rights violation. The effectiveness of HIV and STI prevention interventions is often compromised when interventions to address violence are not implemented concurrently. We also look at community-led services and a community-led approach to planning, delivering, monitoring services for sex workers we find that is essential to make programs more effective and sustainable. This describes the principles of community-led services and shows how they are applied to outreaches, safe spaces, that is to the drop-in centers, and program oversight. We also look at condom and lubricant programming. And this is where we teach the sex workers leaders and the programmers on how to plan and implement the provision of the male and female condoms and lubricants using the approaches outlined in the previous chapters in the sex workers implementation tool. And it covers the planning and managing of condoms, the supplies, the multi-prevention of the commodities, and creating an enabling environment for sex workers. We also look at the clinical and support services of the sex workers, because we see in this tool is the product of collaboration among sex workers, service providers, researchers, government officials, and non-organizations from around the world. So it presents, the module presents detailed descriptions of fundamental prevention, treatment, and care interventions, incorporating approaches outlined in the previous chapters. The STIs and co-infections such as tuberculosis, hepatitis, and additional services such as sexual reproductive health services for sex workers, harm reduction, and post-rape care and mental cases. In this program, we also look at program management and organizing capacity of sex workers, whereby we look at the meaningful participation of sex workers and how sex workers choose how they're represented and by whom, choose how they're engaged in the process, and have equal voice in how partnerships are managed. And this provides a practical guidance on planning, starting, scaling up, managing, and monitoring an effective program from a large multi-site program with centralized management and multiple implementing organizations. Next. So these are the modules that we cover in the Sex Workers Academy Africa. Yes, next. So from the Sex Workers Academy Africa, ASWA has conducted its flagship, which is a one unique of a kind academy since 2014. And through this, ASWA has been able to reach 429 sex workers from 33 different African countries. And this has led to the formation of 54 sex workers-led organizations by the SWA alumni. Additionally, the NSWP, that is the Network for Sex Workers Project, and ASWA has provided grants to the sex workers leaders who participated in the academy. And the small grant is for the sex workers to go and implement what they have learned in the academy through the capacity scan that we do, so that they're able to assess their gaps in their own organizations. And through the academy, sex workers are trained to advocate for improved quality services. And we have seen success stories in countries like Zimbabwe, where the sex workers from the academy formed the ZIMSWA, which is the Zimbabwe Sex Workers Alliance. In Kenya, we have the Kenya Sex Workers Alliance, Malawi Sex Workers Alliance, and Lady Mermaid in Uganda, just to mention but a few. Next. From the Sex Workers Academy Africa, we have good practices and recommendations to all the countries, and this should work toward decriminalization of sex work and elimination of the unjust application of non-criminal laws and regulations against sex workers. Violence against sex workers as a risk factor for HIV and must be prevented and addressed in partnership with sex workers and sex workers-led organizations. And we also have evidence-based recommendations whereby we offer a package of interventions to enhance community empowerment amongst sex workers. Next, please. Thank you.
Thank you very much, Laveria. Really, the Sex Worker Academy Africa is such a wonderful organization and has trained and skilled up so many sex workers for working with their peers and to really bring the SWIT to life so that all of the programs are operationalized and understood with community empowerment at the center. It's really a wonderful achievement that you've done there. So that brings us to the end of our presentations, and we have covered a lot of ground, a lot to think about. You'll have the slides to look at, but we wanted to go now into some of your audience reflections, and if we could have the next slide. Is there a Menti slide somewhere? Here we are. Yes, so some of you may have used the Mentimeter system where you can interact and type in your comments. So we'd like you to go to www.menti.com, enter this code 17573247. You've got a link there that Kerry has put in the chat. If you can click on that, it'll take you straight there. And here you can say, what are some of the commitments that you would like to make here towards bringing community programming with key populations to scale and making it more impactful? We've covered some of the key building blocks, but we'd like to hear from you now as to what you feel you're able to achieve in your country. So think about your tailoring to your own context and situation, how you might take some of the things that we've heard about today, some of the activities and programs and systems that we've talked about, and how they might be implemented or tailored for your own situation in your country. And we'd love you to enter some ideas into this Menti system here. We're going to hear in a minute from some reflections from a variety of people who've joined the session. I've just been taking a few notes here, and I think the trusted access platform is so important, and it's really is about integrating both a physical presence. We have virtual interventions and reaching people through virtual means, but also we have to create that supportive environment that enables a program to operate. So ensuring there's no harassment from law enforcement officers, ensuring that people have access to non-judgmental service providers, they have a safe space to meet and congregate and share ideas and experiences. We've heard about how we need to be very systematic and have almost a checklist of the steps that we need to go through to implement programs. So making sure that we go from the policy environment through the planning, through to the budgeting, getting the skilling up people and standard operating procedures. And then we need both health system strengthening as well as community system strengthening, so that we have both a clinical presence, but also outreach and community-led efforts within the community that really takes interventions and programs to the people. And we don't wait for people to come into a clinic, but we actually have mobile services. We have peers who are known and trusted by their peers in the community. And then the importance of monitoring and evaluation to really check, are we delivering what we want to deliver, and are we reaching the people we want to reach, and are we having the impact that we want at the scale? What is the number of people, the proportion of people that we're reaching by our interventions? And all the way through, we've heard about these complementary approaches, both having a clinical approach as well as a drop-in center, which is more relaxed and enables people to discuss and share experiences. We heard from Laveria about an example of using the SWIT, the sex worker implementation tool, which has community empowerment at its core, and really how we have to build strengthen the capacity. I think communities already have a lot of capacity, so it's not building capacity, it's strengthening existing capacity to ensure community empowerment and community leadership. And that involves a lot of planning, but also mentoring and succession planning, so that we have a succession of people who can come in and be skilled up and take leadership roles. I might go now. If you can continue to enter ideas into the Menti system, I hope you've been able to access that. But now we're going to go over to some other reflections of people who've joined the session. We have 4 people. First of all, we have Aibek Bekbolotov from the National AIDS Commission in Kyrgyzstan. Aibek, please give us a few reflections of the session.
Здравствуйте, уважаемые участники. Если позволите, я могу сделать один слайд, демонстрацию.
Do we have the interpreter there?
Ну, я надеюсь, вам видно. Меня зовут Aibek Bekbolotov, я заместитель директора Республиканского центра СПИД Кыргызстан. Спасибо большое за такие выступления и за приглашение. Я в целом хочу рассказать про ситуацию в нашей стране. Для нашей страны тоже является приоритетом ключевые группы населения. И, как видите, у нас есть вот 4 ключевые группы, которые в основном эпидемия ВИЧ-инфекции распространяется. Это потребители инъекционных наркотиков, МСМ, и секс-работники и заключенные. Здесь видите последние данные биоповеденческого исследования. У нас оценочная распространенность ВИЧ 14,3%, 6% среди МСМ, 2% среди секс-работников и 11,3% среди заключенных. Эти данные, это исследование было сделано в 2016 году, но в настоящий момент у нас сейчас проходит совместно при технической поддержке CDC исследование биоповеденческой среди этих 2 групп. Это МСМ, не потребляющие инъекционные наркотики. Но если посмотреть, мы знаем, что данные возможности сейчас отличаются, и мы хотим на сегодняшний день немножко поменять наши приоритеты, именно направление программ среди самих ключевых групп населения. У нас в стране в этом году пишется новая национальная программа по борьбе с ВИЧ-инфекцией, где мы будем использовать новые данные. Но если в целом взять тенденции, у нас за последние годы среди МСМ-группы идет рост выявления новых случаев. И видите, среди потребителей инъекционного наркотика у нас очень снижается распространенность ВИЧ-инфекции. И у нас в стране основные компоненты направлены на профилактические программы. У нас в программе потребителей инъекционных наркотиков в стране есть программы, все виды практически программы снижения вреда. Это получается метадон, у нас заместительная терапия есть, обмен шприцев, да, пункт обмена шприцев. И в стране внедрены там экспресс-тестирования. И на сегодняшний день мы очень активно работаем по внедрению самотестирования и доконтактной профилактики. У нас проводятся сейчас пилотные проекты среди МСМ-группы. Ну, мы думаем, что это приоритетная группа для проведения доконтактной профилактики. И на сегодняшний день у нас получается, ну, как бы есть пилоты, и они очень проходят удачно. У нас хороший охват по программе доконтактной профилактики. И также у нас есть ключевые группы, тоже являются приоритетами, это секс-работники. Секс-работники на сегодняшний день очень много проблем с этой группой, потому что, ну, как бы у нас, учитывая менталитет страны, то, что мы как бы светское государство, в то же время у нас религия исламская, и у нас есть ряд барьеров в профпрограммах среди МСМ группы и среди секс-работников, потому что у нас идет немножко такие преследования со стороны правоохранительных органов, да, и что немножко ухудшает ситуацию профилактических программ среди секс-работников. Но у нас в стране все ключевые группы из сообщества, из этих 4 групп представлены на уровне странового координационного комитета, где принимается решение на страновом уровне. И ведутся диалоги по созданию условий именно правовых для оказания профилактических программ. Мы больше чем уверены, что, ну, правовые вопросы для профилактических программ являются важными. Да? Последние годы из-за у нас таких рейдов, у нас охват там среди честно говоря, я не слышу перевод. Мне нужно прекратить, я как понял. Завершить?
Yes, if you could, yeah.
Ну, в целом у нас есть такие программы, в принципе, я и завершаю. Если будут вопросы, буду рад ответить.
Thank you very much, Aibek. Again, very innovative work in Kyrgyzstan. Let's move now to Ed Noskin of the Global Fund for further reflections on the session. Ed, please, you have the floor.
Sure, thank you so much, Tim. I'll be brief. And just from the Global Fund side, just to mention that we will continue to promote the concept of trust access platform, both internally and externally in our grant-making practices. As you already know, in the current allocation cycle of the Global Fund, we are much more prescriptive in terms of the key population programs and how countries should focus on prevention in particular, emphasizing the scale in all settings. And this includes, for instance, we provide additional resources through HIV Prevention Catalytic Matching Fund that looks at condom, self-testing, adolescent girl and young women in high-burden setting, as well as key populations, to really strengthen system and delivery platforms with a focus on increasing access to community-based, community-led HIV prevention services. And the countries that you heard today, Ukraine and Kenya, have received this additional support in addition to the co-allocation. What's different this time around is also the way that we negotiate during grant making. We put much more scrutiny in looking at the program implementation approaches. So we talk about the peer ratio, making sure they're appropriate as described in the trust access platform experiences, and looking at how the structural interventions are integrated as part of the disease program, put more emphasis on community system strengthening, looking at the dynamic management of peers, as well as looking at how our support to community services are linked with government support clinics and collaboration between them. And most importantly, in this allocation cycle, we continue to communicate with countries that the countries need to include a full demand, including the focus on HIV prevention with the focus on key populations to be reflected in the funding request and prioritize above allocation requests. If there is no space in the co-allocations, with the hope that some of these demands could be met during grant implementation period. We do have regularly conducted a process such as portfolio optimizations where we identify additional resources, and prevention could still continue to be prioritized during that period. But with all of these additional efforts, we are really concerned about the low coverage and how countries are monitoring this coverage. So we urgently need to make a progress on getting services and programs in a large number of key population in most locations. And this is where opportunity lies in introducing or scaling up online interventions that Purvi presented today. So work is definitely ongoing with technical partners to support measurement of online coverage and coverage of services at physical points. So we have been working as well with some of the implementers, as you may already know, to allow for technical assistance for the design of virtual intervention and as part of strategic initiative that we fund. Moving forward for the Global Fund, obviously we will continue to emphasize the message about the scale, the coverage, and intensity of key population program in our grant guidance, and most importantly, emphasize the concept in the new strategy that is under development. And then working with all of the stakeholders to really think through how to better operationalize it, because we do acknowledge that there are some gaps, particularly in all settings where we see the government picking up domestic financing. Sometimes it's not always translate into a funding for key populations. And Pavlo already said that in the presentation that the coverage can be changed as the subrecipient transition into government funded. So having something much more prescriptive in our policies to stipulate co-financing requirements, that it should focus on key population, continue to be a focus of our work, and make sure that we support civil society and communities to address bottlenecks that stand in the way of making that happen. And with all of this work, of course, with all of the technical agencies and communities to continue to track investment for key populations, among other actions that we think is critical. And I just want to end by recognizing the importance of South-to-South community-led learning initiatives, such as the one that was presented today. This is really critical and would address some of the questions that Job posed in the Q&A section, and making sure that adequately supported it is of paramount importance. Thank you so much, Tim. Over to you.
Thank you very much, Ed. Very important points. And obviously the Global Fund has been one of the cornerstones of supporting the HIV response for decades now. And it's very heartening to hear of the continued focus that is requested within Global Fund proposals to maintain the focus on key populations, and also to look now at this transition towards more domestic funding and how that's going to be the way of the future. Increasingly, we have to encourage countries to allocate domestic resources, to go into partnerships with non-government organizations and community organizations, a social contracting model, so that we have this transition process whereby governments go into partnerships with the community to maintain the response. Thank you very much. We'll come to John Nadiritu now from PEPFAR for your reflections, John.
Thank you, Tim. I will be making these comments on behalf of Tisha from the USAID Office of HIV, and just to outline the priorities for PEPFAR programming related to key population programming. First and foremost, the first priority is carrying up differentiated, crime-centered HIV prevention, diagnosis, and treatment services, utilizing a case management approach, preferably with the involvement of KPs themselves, to ensure that each individual receives all needed services. PEPFAR is also prioritizing partnering with community and civil society groups to improve the quality of KP programs and service delivery organizations. And this includes mentoring, building the capacity of, and increasing funding to nascent KP-led service delivery organizations. Addressing the broader enabling legal and policy environment is also another priority, including reduction of stigma and discrimination that will be present in both public and private HIV and other service settings, strengthening the KP competency of service providers, and ensuring zero tolerance policies among all PEPFAR supported staff and partners. So addressing and preventing violence and various forms of abuse against key populations is a key priority. PEPFAR is also ensuring that in each country where they operate, the countries are utilizing confidential, high quality, accurate, and safely corrected data to understand the size of the key population groups, understand their risk of HIV acquisition and onward transmission, and also understand the service delivery coverage along the cascade in order to inform resource allocation and also the programming. PEPFAR as an organization also strongly emphasizes on coordination both internally within the different program areas under PEPFAR. And this is focused on especially ensuring that services and targeted services and commodities are available for the key population programming, especially in the differentiated sites such as community-based service points. He also emphasizes on coordination with other partners and donors to ensure that we build a high quality, sustainable key population program at the national level. It's important to note that all PEPFAR programming is guided by the WHO Key Population Consolidated Guidelines. And moving forward, we're looking forward and will continue being guided by the upcoming consolidated guidelines for HIV prevention, diagnosis, treatment, and care for key populations expected later in the new year. And also the key population specific implementation toolkits, like the sex workers implementation toolkit, the do it, the transit that have been referred to earlier. So it's quite exciting to see that quite a number of these priorities are actually reflected in the presentations that we've had today. And we're looking forward to continued partnership, and also excited about this community of practice as a forum through which we can also learn and adopt all the good practices that can result in the desired results. So thank you very much for the opportunity.
Thank you very much, John. And absolutely, this is a partnership and we all have complementary roles to play. And by coming together in a consensus manner, we can really make a difference with communities, working with governments, with development partners and donors. We all have to come together. And yeah, this community of practice really is an exciting development, that we will have a forum now to really meet and discuss these issues. So I encourage people to submit ideas for further sessions in this community of practice in these webinars. We'll come now to our last discussant, Judy Chang, known to many of you from INPUD. Judy, please, any reflections on the session?
Thanks, Tim. So just on reflecting on what commitments are needed to scale up key population programs, yes, there's lots of talks, of course, of better health systems infrastructure, non-judgmental and trained, human resource and staffing, logistics and financial inputs, which of course are key. But as many other speakers have also emphasized, we do need real commitment and action, and unpack what that looks like on social and structural determinants. These are absolutely key to scale up, as are the very people at the center. And of course, that is key populations ourselves. So, what makes a key population program impactful and that can work for people who use drugs, gay and bisexual men, sex workers, and transgender people, as services where people feel welcome, that attract people through the door and that continue to keep them engaged, delivered in locations and ways that are more than just acceptable and feasible, but that optimally match needs, schedules, and preferences. And that's from commodities to the right delivery platforms and to the right context and environment. And of course, this will not happen in getting the right mix without the involvement and leadership of key populations all the way from program design, implementation, and monitoring and evaluation. And without addressing, but also, and that means investing in overturning criminal punitive laws and practices that block and prevent engagement in services. So, for example, law enforcement officials that target harm reduction services to fulfill arrest quotas, that prevents engagement, but also without addressing the social and structural barriers, these also limit and constrain movement building and leadership amongst our communities. And without this, involvement and engagement scale up won't be achievable. I think, what also maybe that hasn't been mentioned before is that how legal and policy environments shape attitudes and bleed into health systems and environments. Health is not a neutral space for key populations. Not only is there widespread stigma and discrimination, but there are punitive practices that occur within the health service programs themselves. For example, within harm reduction services, people who use drugs are, often punished within those environments and have like take-home doses of OST taken away from them if they don't follow very strict rules and regulations. So I think, as been mentioned before as well, in case studies, of course, are good examples of key population programs, especially when delivered by key populations themselves. And these offer more than just commodities, but offer person-centered cares that adapt and accord to people's immediate needs, so that people aren't treated as simply a number or statistic. So for example, RAINA, a harm reduction service led by people who use drugs in Kyrgyzstan, in addition to providing the services themselves, assist clients to obtain legal identity documents so they can access social services and government benefits. And that's, a key part, being able to adapt to what people need. And just, a final kind of point is, of course, when we're talking about scale up, we need to maintain, with the focus on quality and person-centered care. So it's not just about, quantity. And just wanted to emphasize, of course, the implementation tools, which have been mentioned by many other people before, the I Do It, the SWIT, Transit, and MISMET. So these are, very important guides. And include chapters on decrim, law reform, and meaningful community involvement. So, thanks.
Thank you very much, Judy, for that excellent summary of the key points that have come out of the session. I think we really have had a very rich session here, covered a lot of ground. It is being recorded, so people will be able to hopefully access to see it again. We need to save all the comments in the chat and the question and answers, and the Mentimeter, perhaps we can get that up onto our site and share some of the reflections of people. We've really been through so many great examples, practical, operationalized examples of where we've been evidence informed. We have monitored and assessed who is getting infected, where are people getting infected, and how are they getting infected. And then we have developed rights-based, accepting, non-judgmental services that are designed to be and tailored for people, with standard operating procedures to ensure the quality and the professionalism of services, and that there is a comprehensive approach that covers people's needs. It's not just about giving out a condom or a needle, it's about meeting people's needs, and when they come into a clinic or when we do outreach and go into communities to see what are the important things that are driving their risk, what are the challenges that they're facing, and especially in these times through COVID, when people have been excluded from social protection mechanisms. I think the trusted access platform mechanism is a very good foundation on which we build our programs. And then we bring in all of the different elements that people have talked about today, and work in a very systematic way, a systematic model that goes through the design and planning and policies to the implementation, the monitoring and feedback from people, so that we can enhance and refine our services, all the while being mindful of the need to really engage people and ensure this is a partnership where services are designed and delivered by communities themselves. So I want to thank you all for joining the session. It will be repeated later on today or tonight. And this is the first in the series of webinars. Our newsletter is coming out, and we also are thinking of a discussion platform, which will be more interactive, where people can raise ideas and give suggestions, as well as bring to our attention some of the acute as well as the persistent problems that people are facing in communities. So we will wrap up the session now. I thank you all for joining, and look forward to further dialogue and discussion within the community of practice. Thank you very much. Good night and good morning to you all.